work, so I am taking care. So welcome you all to this webinar, Zoom webinar. This is our 6th in series and 4th in Young Mind series, Summit series. And today we have Dr. V.Manasa speaking about, she'll be talking about non-pharmacological managements of in ADHD in Indian scenario. And Dr. Prasanna Kumar will be the chairperson. So I request CME committee to say a few words, and then we'll hand over to the chairperson. Dr. Ramanrao Garu and Dr. Indla Vishal.
Thank you, sir. As we know, this is a very important topic because we know only about the Western data. Today we have our own Dr. Manasa, who was trained in in-laws hospital at Vijayawada in PDF. She's going to talk about the Indian scenario of the non-pharmacological management of ADHD, which is very, very essential for all the practitioners, irrespective of whether one is a child psychiatrist or a adult psychiatrist, because we see all types of cases in our day-to-day practice. As we know, attention deficit hyperkinetic disorder is a neurodevelopmental disorder which starts in the childhood and may extend into the adolescence and the even adulthood also. It's a chronic condition. The concept started early in the 1900s till date. It is evolving like anything. Most of the senior psychiatrists, we were well versed with terms like minimal brain damage syndrome, hyperkinetic syndrome of ICD-9, and childhood till the accepted terms of ADHD in the classificatory system of ICD-11 and DSM-5-TR. As we know, ADHD cannot be diagnosed with any effective test, be it a biochemical test or any imaging test. It is a clinical diagnosis. So there are only some differences in the West between the US and the Europe. As we know, in US, its prevalence is reported to be very high, to the tune of 11% in the school age children by 2011, which is an increase of 42% compared to the 2003 survey. In Europe, it was diagnosed much less. I'm sure our speaker will tell about our Indian continent, some data. And the non-pharmacological management of ADHD is the main treatment modality for young children, especially the behavioral therapy. Whereas the combined pharmacotherapy and non-pharmacological treatments are done usually for the older children and adolescents. So I'm sure Dr. Manas is going to deal with evidence-based non-pharmacological therapies in detail that are very useful to the all our psychiatrist colleagues in our day-to-day practice. I'm sure Dr. Prasanna Kumar, who is an experienced child psychiatrist, he will add his expert comments as the chair. So I thank all the office bearers for giving me this opportunity. Now over to Dr. Vishal. Thank you.
Thank you, sir. Good evening, everyone. It's nice to see more than 30 people, 36 people, as I see now, who have logged into this presentation on this evening. Dr. Ramanrao Garu put it very well as he introduced the topic. A couple of other important things is most times parents are not very keen to accept medication at that young age. Even older people, they don't want medication, but young age, one thing is we have restriction on the age. If somebody is 4 years old, very hyperkinetic, you don't want to straight away start medication. Even if somebody is 7, 8 years old, where you can technically start medication, parents could have a lot of objections. So many times, at least in our centers, we try to offer non-pharmacological management. Luckily, we have a big team, so we have the luxury of doing that. But I think at the end of the day, knowing non-pharmacological management helps all clinicians, and there are certain things which can be done in a easy manner without much of manpower. I'm sure Dr. Mansa will throw light on that, and we have a very experienced chairperson in the form of Dr. Prasanna. A few words of introduction about Dr. Prasanna Kumar. He's done his MBBS from Rangaraya Medical College in Kakinada, and then his MD in psychiatry from Andhra Medical College, Vizag. He's done his DM in child adolescent psychiatry from NIMHANS, Bangalore. Incidentally, he's the first and only child psychiatrist with DM super specialty degree in the state of Andhra Pradesh. Of course, we have quite a few postdoctoral fellows, our institute in Vijayawada offers postdoctoral fellowship, but DM in child psychiatry, he's the first and senior most child psychiatrist. His passion in child psychiatry is unprecedented. He's taken a lot of effort to make sure he completes his DM in NIMHANS. He was very perseverant with that, despite being well settled in his career and in Vizag. And apart from that, he's currently, of course, most of you would be aware, he's working as professor in Andhra Medical College, Vizag. He's vastly experienced, worked across the state of Andhra in the combined state, right from IMH Erragadda, Hyderabad, to some of the big private corporate hospitals in Hyderabad. He also briefly worked part-time with our hospital at Vijayawada. And one very nice thing about him is he's a very soft-spoken, gentlemanly human being. And that's a characteristic that is very important when you deal with child adolescent population. He's a very passionate teacher. He's attended multiple conferences, national, international, as a speaker, and also has published many chapters in reputed textbooks on child adolescent psychiatry. So without much more delay, I now hand over to the chairperson, Dr. Prasanna, and to take it forward. Thank you. Dr. Prasanna.
ప్రసన్న గారు సార్
I think his screen froze.
Screen ఏదో అయినట్టున్నది. Dr. Prasanna?
సార్
It is on. Sir, am I audible?
Yes.
I think I
Audible.
have some network issue. I start. Okay, sir. Okay. Thank you, sir. Thank you, Vishal, sir, for your kind words. Actually, I am very sincere thanks to you. Shall we begin, sir?
ఎస్ సార్
Yes, yes. Thank you. Thank you. Good evening.
అక్కడ ఏదో నెట్వర్క్ ఇష్యూస్ వస్తున్నాయండి ప్రసన్న.
ఐ థింక్ వైజాగ్ లో ఏమన్నా ఇష్యూ ఉందేమో అనిపిస్తుంది. ఇందాక మానసిక కూడా హ్యాంగ్ అయ్యిందంట అది.
లేదు ఇక్కడ మాకు బాగానే వస్తున్నదండి. నాకు బాగానే వస్తున్నది.
ఓకే.
Some flickering is coming now, sir.
లేదు అది వాయిస్ కట్ అవుతున్నారు ప్రసన్న
So
మీది.
I will change the network, sir. 1 minute. I will change the network. Why it is happening, I don't know. I will change the network 1 minute.
సార్ వీడియో ఆఫ్ చేసి ఆడియోలో మాట్లాడండి సార్.
Yeah,
కొంచెం
అది
No,
మంచి
లేదు,
idea,
sir.
Sharat.
I will change the Wi-Fi. I think there is some problem maybe. Wi-Fi is good only. 1 minute, sir. 1 minute.
సార్ ఇప్పుడు బాగానే ఉంది, కంటిన్యూ చేసేయండి సార్.
లేదు సార్, ఎల్లో చూపిస్తుంది సిగ్నల్.
లేదు మళ్ళీ అయిపోయిందా? రైట్
Sir,
Sir,
ఇప్పుడు బాగానే వస్తుంది, sir.
రైట్ బాగుందండి ప్రసన్న. క్యారీ ఆన్.
Okay, sir. Thank you.
Carry
Thank you, sir. Sir, first of all, I thank Vishal sir for giving me a very nice introduction. And I thank IPS CME committee for giving me this opportunity, particularly a topic, child psychiatry topic like ADHD, which is very, very important because every day, not only psychiatrists, even a general physician, even a pediatricians, one of the most common child psychiatry disorder is ADHD only. So if you see the prevalence also, not only in Western countries, across the world, ADHD prevalence is increasing. In the last, particularly if you see in the last 10 years, the prevalence is increasing. The average prevalence rate is around 7 to 10%. If you see in different countries, India also is having the similar figures, like around 7% in different studies. So why ADHD? ADHD is so much common disorder, but the treatment has a lot of issues actually. It is not so easy as giving just methylphenidate, or easy like just giving some clonidine or atomoxetine. Why? Because ADHD is not just a disorder which is having which is having an etiological factor of neurobiological. It has a lot of etiology from the psychosocial aspect also. So I will give you an example. For example, if you see an ADHD child who is very much hyperactive, who is very much impulsive, who is having very less concentration or poor in attention, who are satisfying all the criteria as per either DSM-5 or ICD-10 or ICD-11, we may call a ADHD child. If you give him a mobile or if you give him a TV, he will sit quietly. Okay, he will sit quietly for hours together. Or else, if he was taken to a school where the teacher is a very strict teacher, the parents used to say that the child who is very much hyperactive, who doesn't listen at all, in the school, he is very much calm. He is very much, there are no complaints at the school. So why I am telling this example is, a child who is very much hyperactive, who is having a baseline of increased activity levels, if the environment is in such a way like a threatening environment or a very strict environment or a very stimulating or very interesting environment, the child can regulate himself in such a way that it appears we may feel that he doesn't have ADHD symptoms in some settings. But actually he will qualify for attention deficit hyperactivity disorder. So environment plays a vital role. So if you see the treatment aspects, if there are different guidelines for ADHD, one is American guidelines, another one is NICE guidelines or UK guidelines. But if you compare these guidelines, what UK guidelines give is the first line of management is psychosocial interventions. Whereas if you see the American guidelines, they are not so much inclined. They say that the initial level type of management is pharmacotherapy. But ideally, what we prefer, particularly in the Asian countries or from myself or from any other institute, the psychosocial interventions, particularly among psychosocial interventions, parental management training is one of the very important area where the parents should train how to regulate the child. Okay, so there are a lot of aspects in the parental management training. Why? Because why psychosocial interventions play a role is, if you see a child, if you don't give any intervention like either psychosocial intervention or pharmacotherapy, what is the effect of the child? Because many times parents say that, okay, my child is hyperactive, my child is not giving a concentration, I don't want to take medicines, because every child is like that only. Nowadays, if you see in a school, every child is restless, every child is disobedient, almost not following the comments of parents. I don't want treatment. Some parents are in that attitude. So why to treat an ADHD child is another important area. So why to treat is, if you don't treat ADHD, particularly ADHD disorder who are falling under moderate to severe ADHD, okay, where the functioning is affected, what it will cause is, initially it will affect the academic performance. And even then, if the child is promoted, is not treated, and if the child is going ahead, the child presents more with defiant issues and behavioral issues. Even then, if the child is not treated well, the child will have emotional issues secondary to interpersonal problems or in other school issues. Okay, so even then, if the child is not treated, the child may have high risk-taking behavior symptoms, substance use, and finally occupational impairments. Lot of things can occur secondary to these issues. So if you classify ADHD symptoms, there are three core domains. One is hyperactivity. Second one is impulsivity. Third one is poor attention span. These are the most common symptoms we see in everyday practice. But another important thing another important domain what we have to focus in case of ADHD child is the executive functions actually. So the executive functions could be in the type of planning, organizing, abstracting, so working memory, regulation. Okay, so a lot of things will be there in the emotional executive functions. So ADHD is a disorder where they present classically with executive function deficits, and these executive function deficits, if not treated, okay, it can land into severe multiple impairments, either in social, occupational, or any other thing, academic. So is there any treatment for treating executive dysfunctions? So till date, whatever the medication we are giving, either a methylphenidate or etimoxetin or clonidine, any drug, okay, they don't have any significant effect on controlling or improving the executive functions. Okay, so what recent literature is supporting is the executive functions can be minimized only with activities like exercise, okay, or aerobics. The research is supporting only that thing. Whereas what methylphenidate can do is it can improve only working memory. Okay, so the other executive functions, till now there is no good literature supporting to improving of any other executive function deficits. Then how to manage? So the psychosocial interventions are one of the major role. They play major role in controlling majority of the behaviors what we see in the ADHD. So with this brief introduction, we have a very good speaker, Manasa. I know her. She worked with us in our unit. I was faculty when she was doing postgraduate in my unit. I know her very well. She is very good in academics. She is very punctual. She is very much interested in the field of psychiatry, and she took child psychiatry. I'm very thankful to her. So I will briefly introduce her. She did MBBS from Andhra Medical College, MD Psychiatry from the same Andhra Medical College, particularly from our hospital, like Government Hospital for Mental Care. Later, she did PDF from the PDF Child and Adolescent Psychiatry from In-Laws Hospital under the guidance of Vishal sir. She is very much interested in child psychiatry. She is a very good clinician also, and particularly in the child psychiatry. With this brief introduction, I want to I request Dr. Manasa to go ahead with her presentation.
Anil Martin garu sharing option ఇస్తున్నారా? సార్ మేడం మీరు షేర్ చేయగలరా? చూడండి ఒకసారి.
చేస్తారు సార్, వాళ్ళే చేస్తారు, ఏం ప్రాబ్లం లేదు.
నో ప్రాబ్లం. ఓకే.
Yes, sir, I'm able to. So, very good evening, everyone. Thank you, Prasanna sir, for this warm introduction, sir. So, I thank IPS AP State Branch for giving me this opportunity. So, I'll start the presentation. So initially, like I have chosen this topic because during my initial stages of my practice, I had a child with ADHD. So I started him on methylphenidate, and the academics of the child, everything has improved. But the father still used to complain that why there is no much improvement, madam. So I need more improvement. When I asked about that, why he's thinking so, he told me that I have to plan everything for the child, then he's doing improvement. So the planning part or execution, that was lacking in the child. So then I thought maybe these psychosocial interventions, non-pharmacological management is very essential to show more improvement in the child. So as we all know that ADHD is a neurobehavioral disorder. So it can affect academical progress, social impairment can be there. And these things continue to exist in the adolescence and also into the adulthood. So what are the domains of improvement we usually see in ADHD? There can be problems in the academics and problems with the relationships, either with friends, adults, or with the siblings. They have low confidence. And as sir was saying, there are as he grows into adult, there is a problem with while functioning in groups, and there may be some problems with his academic function. And there was a study done by Pelham et al. It was a multi-randomized study. It has shown that when there was a behavioral intervention done along with the medication, there was greater improvement compared when the behavioral therapy was started later than the medication. So what are the non-pharmacological managements we usually do? This is we do behavioral management, where we train the parents, or the classroom interventions can be done, or the peer-based interventions also can be done. And the training program to the clients themselves, it can be cognitive training, neurofeedback, occupational therapy, or cognitive behavior therapy can be done. And some neurostimulation techniques and physiological treatments like exercise, yoga, and diet also can be done. So what exactly are we targeting in these therapies. Like, of course, we target on the inattention part, hyperactivity and impulsivity, the core symptoms of ADHD. But the main thing that we focus in the psychosocial interventions is like executive function. So the child can have working memory deficits, and he can have procrastination, poor in problem solving, time management can be poor, and most of them complain of disorganization, and they have mood swings or risk-taking behaviors. These can be addressed with these psychosocial interventions. And the first one, coming to the behavioral modifications. So here we train the parents and also teachers, and also like even in the therapy centers also, even the psychologist does this behavior modification. Here what we usually teach them is like operant condition principles are taught, where the positive reinforcement is given, like the praise, or negative reinforcement like ignoring the inappropriate behaviors. These are done, and this is called like contingency management. So by these techniques, we usually try to increase the desired behaviors and reduce the undesirable ones. And when the parents are included in these things, it has shown that the relationship between the parents and the child has improved. And also like the improvement in the child is more along with the, when it is given along with the medication. So like a few months back, we had a 9-year-old child. He lives with his parents and sister. He was in his 4th grade. The concerns with which the family brought was like he used to have frequent fights with the siblings and difficulties in sleep. And he used to keep his room messy, even his notebooks, backpack, everything was messy. And he used to lose the things, avoids the homework, resistant to sleep and at bedtime. And also he used to be slow in his routine, poor hygiene. And we were very fortunate that when we have sent a school teacher report form to the school, the teacher was kind enough to inform us more about the child. Like the child was restless, scholastic performance was poor, and he used to avoid writing in the school. So there was incomplete classworks and all, unable to concentrate, and he used to be stubborn and frequent fights with the friends. So there were very short-lived relationship. And at times he seems to be lost, and there was lack of self-control and all. So here we started him on medication, and along with that, we started him on parent management training. So the parents were psychoeducated regarding the ADHD, about what the symptoms can be there and how it can influence the child. So we have planned the sessions, like initially we psychoeducated, then like how to communicate exactly with the child, like the instruction should be clear, specific and short, and it should be a consistent thing, and always try to catch the child good and try to appreciate him and cut down the critical comments. And even we advise the parent about the self-care, being patient, and always try to include playtime with the child, and parents being the role model. And the next sessions, we concentrated on environmental modifications, like dealing with hyperactivity, how they have to change the environment at home, like allowing some legitimate breaks between the therapy, and also have short breaks between the assignment, and how to breaking the task into simpler ones, or breaking the large one into simple ones, and supervise closely, and how to change the environment with regard to inattention or disorganization, like make him to sit near a good role model, like his sibling or someone, and give and like a frequent and immediate consistent feedback has to be given. Immediate feedback matters a lot in behavior modification. And also redirect if he is getting deviated, like frequent and immediate redirecting him also helps. And also like we have taught him on token economy and how to give points and star charts at home, and anticipating the things, like if they take him outside, and they may anticipate his behaviors and try to educate him about that. And the very important thing is we ask them to be in continuous touch with the teacher, so that the teacher can give him feedback. So while these sessions, what we need to know, the first thing is like what are the unconditional things and what can act as contingents, so that we can give them as rewards to the child. So the love, respect, safety, like 3 meals or essential clothing or temperature control, these are the things which the child has to get unconditionally. But few things which we can use as rewards are like some special foods which the child like, or some extra video game time, or some trendy clothing, or Wi-Fi password, or something which the child likes most. These things has to be used as the contingent things. And if and also like the reward should be given immediately, and we should always try to catch the child being good, and positive attention should be given immediately. and we can establish some rules, and the clear consistent commands has to be given. And if the child is doing some undesirable things, we can go for timeout, which is like he'll be taken, the privileges which the child is supposed to enjoy are being taken out. And while doing this behavior modification, few things has to be avoided, like negative phrased statements. These things has to be avoided. And even the emotional threats, like the parents may say that like, for you, we are doing all these things. These kind of threats should be stopped, or empty warnings or threats like, so if suppose you are going to do this, I'm going to leave you in this place and I'm going home. So anyway, we are not going to do this, so we cannot want such kind of things. And the promises which we are not supposed to, means like suppose we may promise, like if you complete your homework, I'm going to give you 1 hour of screen time. If you're going to do that, promise, otherwise they cannot do that. And also like once they promise something and child is not doing the work, then we are supposed to take out the privileges. But at times what happens is then the child continuously pesters for them to give. So then then the parent can yield and they can give those rewards. This is not advised. And even for parenting also, we usually advise them like measures, like we ask them regarding the praising, criticism, or how many times the child has been praised, how many times the child has been criticized. And even the child behaviors also can be addressed, like they can be measured, like how frequent the child is presenting those behaviors and how intense they were. And this is the example of the star chart which the parent can maintain, like each activity and how Monday, how many stars he got, like and after how many stars we are going to give him. See, like so for 30 points he got 23, and the parent has given some new toy to him. And also the research has shown that the involvement of father has shown more improvement during the behavior modification, because the child with ADHD has some poor sportsmanship. Because of that, like he has difficulty in maintaining the peer relationships. So when we involve father, it has been found that the emotional regulation, social cognition, and even the focused attention of the child has been improved. And even the problem related behaviors are also decreased when compared when one parent is involved. So next comes this classroom interventions. The evidence has shown that the positive teacher and pupil relationship has shown promising improvement in the child with ADHD. So for this, like we need to do some modifications, like some classroom modifications, like keep making the child sit away from the windows or doors, and making him sit right in front of the teacher, or like making him sit with a work buddy, or allowing him to take some frequent breaks. Like the teacher can involve him by asking him to collect some books or distribute books, or making him to sit in a quiet area free of distractions. And during the teaching methods also, the teacher can initially start using some visual charts or pictures or some colors or like that, and also to write on the board regarding like what activities they are going to discuss. And she can use some cues also, like pasting something on his desk, so that will remind the child about the things that he has to focus on the lesson, or like the teacher can touch his shoulders so as to bring him to the to get his attention back. And if at all there are some behaviors at the school, like even we can teach we can also ask the teacher to show this behavior modification techniques, like rewards, and using negative reinforcement by ignoring his behaviors. And also like we ask the teacher to maintain a report card, so that they can give this to the parents, so that the parents can also be aware and they can understand like what are the things that can be focused. So the research has shown that like even the peer role models and the mentors has shown that inclusion of peers help the child in improving his social competence, along with the other things, because the child who is well trained can help the child with ADHD in by improving his behaviors, and also helping him to complete the notes and all in the class. So now comes the training interventions to the child per se or the adolescents. Like they can be like cognitive behavior therapy, or like a cognitive training or occupational therapy and neurofeedback. These are the things we focus in the child. So this comes the cognitive behavior therapy, where we this is the main thing where we try to address the core symptoms of ADHD, like inattention, hyperactivity, and impulsivity. Along with that, we also focus on social and occupational dysfunctions that happen in the child. So we help them to identify the faulty and unhelpful ways of thinking and his behavior, and improve their coping skills. So we had a 15-year-old child, like who has been brought by the parent for his restlessness and interrupting during the conversation, forgetting easily, and not doing well in his studies, and not able to complete his work. And at times he used to leave his answer sheet also blank. So when I inquired, so these things have been there since childhood, and the teachers also used to complain this to the parents. So like he never listens to them while studies, and he cannot sit at least for 5 minutes, and he leaves from that place. And even the similar things continued at the tuition place also. And the parent also used to complain that he's disorganized, throwing his clothes or books, and poor table manners. And the child was also reluctant to attend the college, saying that he's not able to make some good friends over there, and he's not able to enjoy over there. So we started him on the medication, and also we started him on the CBT, cognitive behavior therapy was given. So initially how we planned the sessions, we educated the child about the ADHD and what symptoms it can have. And we trained him regarding the organization skills and planning, and improved his time management skills, and like how to plan the things, and how to schedule his activities, and how to break the task, and how to reward himself when he has completed the task, and also how to reduce his distractibility, increasing his attention span, and even the problem solving skills also has been taught to him. And also we advised him regarding how these things can help him in his future also, when he goes to the job or like higher studies, how he can implement the same things. And luckily the child got interested in studies, and he has shown a lot of improvement. He has become so competent enough, and he used to compete with other students in the college, and he scored a seat in NIT. So a research was done by Monica Sharma et al. They are the MPhil psychologists at MIT University. They have done CBT and parent management training in a child with ADHD, and they have found that like the mother has clearly shown, mothers reported that the child has shown improvement in hyperactivity, sustained attention, and also the compliance in his behavior, increased compliance, and also there was behavioral regulation in the child. So mindfulness is another technique we usually combine with ADHD. So here it is based on the principle that being non-judgmental in accepting and being aware of each moment as it comes, and which requires focus and attention. Mindfulness has shown the improvement in inattentive type of ADHD rather than this hyperactivity type. So here actually we had a patient around 26 years or like that. She came to us saying that like she's at the verge of losing the job because she wasn't performing well. Even she has been receiving like from past a few months, she had been given many warnings from the boss, and she had issues with the husband also, because husband want to start a family, and she's feared that because she being disorganized and not able to plan, she's worried that she may not manage kids and all. So we started her on cognitive behavior therapy. Along with that, we started here on some mindfulness regarding the mindful awareness of how these ADHD symptoms are influencing her, and how it is influencing her day-to-day activities, and how to be aware of the thoughts and how these are being influenced because of ADHD. So next comes the cognitive training. Here, like we use some apps or like some software to improve the cognition of the child. So Endovirax, this is the FDA approved cognitive training program for treatment of ADHD. Here, it's not like a video game. Actually, what they do is they try to provide the child with some sensory and motor stimuli, so that the child can improve his cognitive capacities, and he is able to shift the attention between the task and also ignore the distractors. So on here, there are some other apps like Working Memory, CogMed, and Orange program. These can also be used. Here we try to improve the executive function and working memory. These are some of the programs which can be used for an ADHD child, like Accident, Captain, Log, CogMed, CogniPlus, Locuture, Play Attention, Rehab Form. So P.S. Saha et al. Has presented a case in which after training the child with these cognitive programs has the processing speed, the visuomotor coordination, sustained attention, and the working memory has improved in the child. But of course, the higher cognitive functions such as planning, organization hasn't shown much improvement according to the study. And even the cognitive training can also be done at therapy level, like by using some attention enhancement tasks like coloring or beads, grain sorting, solving the majors, or like letter cancellation, joining the dots, or like that. And working memory also can be improved by a series of numbers or words, or spotting the images. And also it can be improved by some token economy, like giving stars or points to the child. This is how we usually maintain the progress of the child. Like we give an activity and we try to observe like how many distractions he had and how much time he has taken to complete the task and how many errors he has done. And like over time, we try to see like how much he has shown the improvement. So the metacognitive skills, like here, what we do is we ask the child to question himself. Like while doing a task, like while doing the task, we ask him to question himself, like what he's doing and how we will start, and what is the importance of planning the task. And we also ask him to think, like if he forgets one step in his plan, like what he's supposed to do. And while during the task also, we ask him to question like what he did and whether whatever he's doing, whether he's doing in a proper way, and how it is similar to the things what he has done before. And after completion of the task, we ask him to question himself, like whether he has done the things in a proper way or it is correct, and what he liked about the task and what he doesn't like. And if the child, we advise them, like if the child finds it harder than 3, then we used to ask him to rate on a scale. Like if he finds it harder, then we ask him to find an easier way to complete the task. And we ask him to question like whether he's having fun by doing a task, whether it comes to his work or like, and how much important it is to him. And the problem we see in like ADHD children is like they are very poor in organizing. So this organizational skill training is also very important to them. So the best defense against manipulation of our attention is to determine for ourselves in advance how we want to invest it. This is the saying by Mr. E. Kohlberg. So during the organization skill training, we teach the child about daily planner and how to do the list, how to break the task into simpler ones, and time management. And this is the example of the timetable which the child can set, like he can break that task into simpler ones and give specific time to each one. And social skills training. This is the one thing that lacks in a child with ADHD, because they are not able to maintain good relationship with his friends or family, and they have very short-term relationship. So social intelligence is something which recently is coming out. Like it's not directly contended with the academic intelligence which we test through these IQ tests or like that. So we try to focus on improving the conversation skills of the child, like how to greet and how to introduce himself, actively listening to them, answering to the questions and interrupting them when necessary. And like friendship skills, like how to make friends, how to give compliments and how to give thanks, and how to join in group activities. And also we advise them on difficulty skills like accepting no, and if somebody criticizes, how to react to that. Those things will be taught. And even the problem solving skills also, whenever there is a problem, how to negotiate and how to take help from others. These things are taught in the social skills training. And during the social skills training, what we do in our clinic is we usually use some picture puzzle game. Like in the group activities, what we do is like we try to give some puzzles or some jigsaw puzzles or anything, like where there are number of pieces. We give an activity to the child, and if the child completes the task, then he will get one piece of the activity. Then again one other activity. So we try to give him some 10 to 15 activities, and if the once he completes every activity, then he is going to get one piece of the puzzle. So the number of pieces he gets, then we will decide like who has got the more pieces, and we try to include the child, like who has gained more pieces, to advise the other child and how he has done those activities on that. And this can also be done by making the child of the day, like we take group sessions, like some 5 to 6 kids, and we ask one child to organize the activity, or by role playing also can help. And even the projective techniques, like we ask the child to express his feelings and emotions after the group activity and all. So next comes the occupational therapy. Like the research has shown that even the ADHD child has shown some problems in their sensory issues, like they can have some sensory issues. So whenever a child comes to us, we usually do some sensory profile. Occupational therapy assessment is also done. And if at all the child is found to be having some sensory issues, we start them on occupational therapy activities. So we had a child of 4-year-old. So he's 4 years, so we cannot right away start him on medication. So we started him on behavior management training, like parental training is included, and also some behavior techniques are taught to the parent. And along with that, we started him on occupational therapy. So the complaints the parent has given is like he spends most of the time outside climbing the furniture, trees, and he's always on go, and he used to hit others, spit, and doesn't want to wait, and there's difficulty in his speech also, and he has no interest in this tabletop activity. So there is he has difficulty in holding attention. So the child used to come very eagerly to the clinic, and once he comes around, because it's more like a playroom, so he used to come and he starts on like trying to play everything, and he runs everywhere. So initially when he comes, our OT used to hold him and start some deep pressure with a ball. Then they used to use this dark room to calm him down. And also, if required, we used to use some weight curves or bolster swing and giving some mild movements and all. And at times, like to channel his energy also, what we used to like, we used to give him some trampoline activity, and along with that, we used to include some other activity like completing a puzzle. So I have some videos. So what we do to the child when he comes to us. So this is the balance board where we try to improve the balance of the child, like in the occupational therapy. So here, along with the swing, we try to include some other activity to the child so that he has to complete that puzzle also. By this, the planning and also inhibitions also improve in the child. And these are some kind of walks. Animal walks also improve the child activity, like they improve his proprioception. So, and we try to include this with other activity, like bringing one toy from the other end of the room to the other end. So ball compressors, this is the sensory blanket which the child is rolled on, and there is ball compressors are being given. And this is the obstructive activity we usually use for ADHD. Here the set of tasks are given to the child. Like they are given multiple, like walking on the balance beam and avoid these bars and all. So these are all some of the activities we do in our clinic. And also, like when we do the sensory profile, like when there can be issues with all the 5 senses we have, and along with that, in sensory profile, we try to assess the proprioception and also vestibular system. So like when there are issues with the tactile system, like we do some of the activities like playing with the sand, finger painting, like playing with the Play-Doh, playing with sponges, or like some arts and craft activities with rice, beans, glue, sand, or etc. Or some dressing activities, like we ask them to touch different kinds of textures like fabrics, and some water games also help, blowing bubbles, cotton balls. These things help. And when coming to when there is a problem in the proprioceptive system, the therapy can be given like a passive therapy and also active therapy. Passive therapy is like we give some compresses, deep pressure compresses to the child, like the weighted blanket or with the massage ball we try to give. So the bear hugs can be given, rolling on a yoga ball, backpack, or weighted jackets can be given. In the active, where the child is actively involved to do some heavy work like the animal walks, like the crab or frog rapids, which I have shown in the video, the digging, jumping, stamping, pull and push activities, wheelbarrow walk or walking to a tunnel, cleaning the board. So on some push-ups, carrying groceries, these things can be given. And there are problems with the vestibular activity. So when there is problem with the vestibular system, they can go like passing the ball, sack race, or three-legged race. The swings help a lot in this. And standing on one leg, rocking chair, the balance beam, scooter board, and the skateboard. These things can help. Bike riding, wagon ride, spinning on a chair, or like walking on the balance beam. These things can help. So like the research has shown, like even the ADHD child, the child has problems with sleep also. So we always advise them on the sleep hygiene because it improves overall health of the child. So like we advise them on sleep hygiene, like ask them to keep on a regular routine, like to wake up and sleep at the same time on every day. Of course, like at the weekends, they can take, they have some minor changes. And always try to engage in some relaxing activities during the bed, before the bedtime, and keep the sleep environment ideal, like comfort and cool temperature, adequate darkness, some good mattress, and avoid the stimulants like caffeine, alcohol at least 2 to 6 hours before sleep, and avoid the electronic gadgets at least 2 hours before, and improve, and including some exercises in the daily routine. So next comes this biofeedback therapy. Here we use the operant conditioning principles, in which the patient is taught to control the bodily functions such as heart rate, breathing, to improve his symptoms. Here actually for ADHD, what we use is either EEG or fMRI to modulate the brain activity. So like the research has shown that the ADHD children has decreased beta activity and increased theta activity. So the beta activity has been shown to have positive relation with the attention, and the theta activity has negative relation with the alertness. So we try to reverse these conditions by using this biofeedback, neurofeedback. So a research has been done at NIMHANS by E.A. Sharina under the guidance of Dr. K. John Vijay Sagar. So they have found that neurofeedback has improved the cognitive deficits and helped to reduce the ADHD symptoms and also behavioral problems. And of course, this has consequently improved the academic performance of the child. And these improvement has stayed for about 6 months in the child when there is a follow-up has been done. And also the PhD thesis in Andhra University has also been done, and has shown neurofeedback has shown improvement in child with ADHD. So the physiological interventions. So exercise plays a very good role in improving the neurocognitive function of the child. So the aerobic exercises, they create new pathways in the brain, and they help to improve the attention. Like the activities like running, brisk walk, biking, and swimming also helps. And even the martial arts like karate, taekwondo, judo has shown to improve the self-control and bringing together mind and body of the child. So it is advised like for a 6 to 17-year-old child to involve at least in 40 minutes to 1 hour of physical activity every day. So it eases the stress and anxiety of the child. So research has been done by S. Jayanti et al. In 2021. So they have given some 6-week structured exercise program, including aerobics, resistant exercises, motor skills, and attention training. And they have shown that significant improvement in physical fitness, motor skills, and attention in the ADHD children. So the same team has done a systematic review where they have shown that the studies reviewed were like moderate to high quality and reported benefits of various exercise programs in improving motor skills, physical fitness, attention, and social behavior in children with ADHD. So next comes the yoga. So like as per the research done at NIMHANS under the guidance of Dr. B.N. Gangadhar by Dr. V.R. Hariprasad et al. They have started on some 8 yoga training sessions and were given to the subject where the yoga was learned reasonably well. And after 8 sessions of yoga, they have found the significant improvement in the ADHD symptoms of the child when they assessed on Corner's ADHD rating scale. So that dietary interventions, which may play an important role, but like there are no specific recommendations for that, because though people say that like the sugars can increase the hyperactivity, but the studies hasn't supported much. But the studies show that when the child shows some hypersensitivity to certain kind of foods, these has to be eliminated from the child's diet. So this has improved has shown some improvement in the child, and even the research has asked to avoid the avoidance in artificial coloring agents and preservatives has to be avoided, and supplementation with omega-3 free fatty acids also help. Like 300 to 600 milligrams per day dose is advised. And next comes the neuromodulation techniques, the either RTMS or transcranial direct current stimulation. These has been done in RTMS, like the stimulation is done in the dorsolateral prefrontal cortex, which is the area for executive control. So when they have rated on the coroner's rating scale for ADHD, the improvement there is improvement in the hyperactivity symptoms, but the improvement in attention hasn't shown much. So even the clinical practice guidelines for therapeutic use of RTMS by IPS has shown it hasn't given any no conclusions has been drawn from the studies, and even transcranial direct current stimulation has even the guidelines show that it is under experimental stage only. So like the non-pharmacological treatment in India, the study has been done by Satpathy et al. It has shown that though there has been a lot of improvement in ADHD, non-pharmacological management of ADHD, like using psychosocial treatment to social and behavioral skills, even more sophisticated neurocognitive techniques like using some cognitive training apps or programs. But when compared to literature from the West, so the research has been very little, and there are only limited Indian studies about that. So it suggests a huge gap, and it suggests the future studies to be involved in these areas. So these are my references. Thank you.
Okay, that is a very wonderful and very lucid presentation. Thank you, Dr. Manasa.
Thank you, sir.
We have questions actually today. One question is from Dr. Chaitanya. The question is, does cognitive therapy actually for moderate and severe ADHD? I think her question is, I think there is some error. She wants that whether cognitive therapy is useful for moderate to severe ADHD. That is, I think that is her question.
Yeah, along with the medication, we can definitely use, like even in our center, we use some cognitive training programs where it helps. And along with that, we include some cognitive therapy programs during the behavior modification. When it is included along with the behavior modification, it definitely helps.
Okay. So I want to add some more things regarding this question, actually, cognitive therapy. So there are a number of psychosocial interventions. I think Dr. Manasa has enlisted a very good account regarding different psychosocial interventions. Among them, if you see the psychosocial interventions, the timing is very important. So some interventions are useful in preschool age, some interventions are useful in school age going children, Some interventions are useful for adolescents and some interventions are useful for adult group. So which interventions we have to focus is another important area. For example, if you see the caregiver interventions, what Dr. Mansa has discussed regarding particularly the parental management training, those interventions are very effective if you do give during the school age period. Okay, so whereas these interventions like a cognitive behavior therapy or mindfulness training, those interventions will be useful when in the adolescents as well as in adults. Okay, because the basically the cognitive training or cognitive behavior therapy basically focuses on the awareness of the person regarding her deficits, particularly the inattention, unable to inhibit the impulse. Those things once he goes into adult, when we educate them, when he realizes that that they have some impulsivity, because of their impulsivity they are having number of issues, they can try to regulate themselves. So CBT is usually recommended during the adolescent and adult period, whereas the caregiver intervention, particularly the PMT or the interventions to school age, are we give during the childhood period. So I think that thing I want to add.
Raman
Any,
Rao,
any other questions?
Raman Rao,
Sir.
Yeah. I have some, in addition, what are the levels of evidences for this, as our Prasanna Kumar was telling? I have just seen in one of the guidelines by AP, American Psychological Associations, that the level of evidence, especially for the social communication, social skills training, and the cognitive training, is very, very less. In fact, the level of evidence is only 5 for social skills training. As he was talking about, depending upon the age, probably it may vary. But the suggestion is that level of evidence is number one for behavioral therapy techniques like parent training techniques, or peer training techniques, or classroom techniques. These are highest level 1 evidence. Whereas for social skills training and cognitive training, level 5, almost they're not useful. That's what they were mentioning. What is your comment upon that? Any idea?
Yeah, yes, sir. Like the behavior modification plays a major role in all these techniques, and these are the supportive management only. Pure cognitive training is not going to improve all the ADHD symptoms. It is going to it acts as an add-on therapy only for them. Even the social skills training, because there are issues in the child regarding how to maintain relationship with his peers, and also we advise them on these social skills. If it is not done along with the medication or behavior modification, but we cannot expect any improvement in the child.
I think there is another question: how to manage parental burnout and blaming each other for child symptoms?
So, like as I quoted in the child, the involvement of both the parents is very essential for improvement of the child, because it adds to them, and both of them can support each other. And even during the parental sessions, when we are psychoeducating them about the ADHD and how the child can present to them, if at all, if we find that the child is, if the parent is having some depression or anything like that, or if he's anxious or like that, we need to address those things also. So this can help. And we can also, during the psychoeducation, we can also teach them about the prognosis the child can, with these therapies or the medication, how the child can improve, how much we are expecting, and how the child can be in the future. All the positive aspects, when we show like the literature, like this much improvement the child can show, like then this can reduce the burnout in the parent.
I want to add some more things. If you see the caregiver burden, particularly ADHD, there are a number of studies supporting that there is a significant caregiver burden. Particularly, the parents can go have a depression, the parents can have significant anxiety, lot of marital issues can happen, blaming can also happen, because many times ADHD is one of the major etiology is the genetic. So many times the the mother can notice that whatever your behavior is there, how you behave, the same thing is there in your son. Like that, the mother will blame the husband, mother will blame the father. So in that scenario, what we can do is we can say that it is not the disorder is due to no one's mistake. The father is not responsible, the mother is not responsible, or the child is not responsible. It is the disorder actually. We can give a detailed biological account how the disorder evolves. Like it is basically the disorder is secondary to neurotransmitter imbalance, particularly the dopamine, the norepinephrine, these chemicals which are normal in everyone. In some individuals, because of different issues, they can there will be a neurotransmitter imbalance, and this can lead to these symptoms. Like that, if we try to educate, and many times they even though they have a lot of burden, they refuse to start medication actually. So in that case, a proper psychoeducation is very important, and not blaming anyone regarding the child's illness is another important thing we have to focus. Any other questions?
Sir, one more question.
Any comments on anger management skill training in poor frustration tolerance on aggressiveness in ADHD?
Yeah, so if the child, when we are doing some behavioral assessment of the child, like if a child has these anger management issues, then we can include these things also in the cognitive behavior therapy sessions. So anger management can be dealt in detail, and also we also teach him about the ABC techniques, like what are the antecedents really that are triggering his anger, and how to control that, and what are the consequences of his anger. So these things are taught in detail to the child, and this helps the child in anger management. Of course, the age matters here. So if the child is below 10 years or like that, maybe he may not be able to manage much, but even the simpler techniques can help him.
Raman Rao, sir.
Yes, sir. Sir, one basic question is, are we overdiagnosing ADHD? Because, it was exponentially increased, the prevalence rates. Is more of a subjective diagnosis. As our chairperson was talking about, a child is very comfortable when he was dealing with what he wants, like seeing a movie in a YouTube or watching a TV program. But at the same time, he is not comfortable in the classroom. So, in fact, when we were students and when we were taught by Dr. Shobha Srinath, when we went to NIMHANS, and in those days, in fact, they used to say that the child is okay if he's able to sit for a few hours and watch a movie. There's no need to diagnose anything like hyperkinetic disorder in those days. But over the decades, there is a big swing, and now the diagnostic criteria have changed, and things are, are we overdiagnosing? Because I read sometime back that because methylphenidate is overused, and there are so many legal cases pending against the pharma people also. So, what is your comment, both the speaker as well as the chairperson?
Mansa, can you answer once?
Yeah, yes, sir. So like overdiagnosis, like usually when we diagnose any child with this thing, we try to check any difficulties in academics, occupational, social dysfunction. When the child is having such dysfunctions, then we start him on treatment. Otherwise, initially, if it's very bothering to the parent, then we can start on psychosocial interventions rather than starting him right away on the medication. But at times, like it depends on the parental thing also. Like usually even mild things also, the parent may get frustrated, so we need to assess the parent also, like how much exactly. So that is why we assess how many times the parent is criticizing him, how many times they are rewarding him, and how many comments they are giving. And we try to assess the intensity and also frequency of the child behaviors. So by this we can reduce this overdiagnosing the child. And of course, there are situations where we may overdiagnose. So initially, it's always better to start with psychosocial interventions if you have little doubt about the diagnosis.
So I will add this overdiagnosis. If you see from the last 10 years, if you see the statistics, not only in India, even in US studies, the number of kids diagnosed with ADHD is increasing. The number of kids receiving psychosocial interventions is increasing. The number of kids receiving medication is increasing. So there are few papers that because of the pharma promotion and all these things, the diagnosis of ADHD is increasing. Like that, there are a number of papers also, what sir is telling. But what I want to say is, compared to 10 years ago, every parent wants kid to be perfect. Okay, every particularly not only parents, even the school also. Suppose in earlier days, if we see a kid who is not focusing or who is not studying well, they don't give attention. Okay, but in recent, even if the kid is hitting other kid also, the teachers will call the parent and just tell the parent that your kid is hitting. But nowadays it is not like that. The parents as well the schools are wants the kid to be perfect in every area. Now they do, even if the kid is not focusing, if the kid is not sitting in the class, particularly if you see in the Western countries where I have many children who from US, the parents say that if the kid doesn't see when when the teacher is telling, the teacher will subject to psychological assessments. So once the psychological assessment is positive, they will be seen by a prescription psychologist, and based on the scoring, particularly whatever the scoring ADHD is, they will start methylphenidate. I have some kids who are there with having a dose of around 60 mg of methylphenidate for mild or moderate ADHD symptoms. Why? It was given by a prescription. They told who has prescribed in that. They told that it is a prescription psychologist in US like that. Actually, the father is also doctor who has shown to me. So what I want to say is, one thing is the level of awareness regarding ADHD is increasing day by day. Not only in psychiatrists, even pediatricians also. I see some pediatricians where they diagnose ADHD. And now time there are among pediatricians, the developmental pediatricians, even pediatric neurologists are coming where they themselves will be giving medication. So the field is increasing, particularly now the field is increasing. There is a cultural acceptance of ADHD is there, and the perfectionism in the child to be in every aspect, not only in focus, in the decreasing the, now the parent doesn't, parents are not accepting if the child is very hyperactive, if the child is hitting other child, the parents won't accept. Now they are bringing the child to a psychiatrist nowadays. I think compared to 5 years ago, the awareness is also increasing. And another thing is recently after Corona also, the behavioral symptoms, particularly the ADHD symptoms and the ADHD disorders, in my clinical experience, the cases are increasing. So this is a few things I want to add. So any other questions from the audience? Sir, shall we wind up, or can we take some more, sir, questions? Sarath garu?
Sir, we can wind up, sir. We can wind up.
Okay. Thank you. We have a very wonderful session. I will just give a summarize of this account. What's the today's program? The psychosocial interventions are the first line level of management in case of ADHD. And the another important point is psychosocial interventions are universal. It is not the medication universal. The psychosocial intervention should be given along with medication. So medication, many times if a ADHD case comes, our pen directly goes to medication. So it should not be the practice. The psychosocial intervention should be the starting point, and it should continue. Medication is complementary. Okay. The third important thing is the parental management training. Everyone should learn. Parents, there are simple techniques, simple things like praising the child, positive reinforcement, the negative reinforcement, differential, we call it the differential reinforcement, setting limits, clear commands. Okay, these are the few important things everyone should learn how to handle a ADHD child. Dr. Manasa has given a very good account, and she has covered almost every psychosocial intervention for ADHD. Thank you, Dr. Manasa, and thank you, IPS KP committee for giving this opportunity. Thank you all. Back to CME committee, sir. Vishal, sir.
No, well, thank you everyone, and Dr. Mansa, very nice presentation. Especially, it shows your rich experience in working in this field. And same goes for Dr. Prasanna. His wisdom in this area has enriched our insights into this topic, which we are now seeing a lot more. Thank you, IPS AP chapter, Dr. Sharath, Dr. IVL Garu, Dr. Murthy Garu, for choosing a wonderful topic, speaker, and chairperson. Thank you, everyone.
Kishore, vote of thanks. Kishore.
Yes, sir. I'm ready, sir. In business, sir.
వినిపిస్తుంది చెప్పేసి.
Sir, good evening, everyone. It's my pleasure to present vote of thanks on this occasion. First of all, we thank today's speaker, Dr. V.Manasa Ram garu. Manasa Ram garu. So for enlightening us on this topic, so it is really wonderful, madam. We have shown with a lot of videos. We are very thankful to you. It was very nice. It was really enlightened us. It would be really a good thing for all the PGs and the participants. And I thank Dr. N. Prasanna Kumar garu, who chaired this session. And I thank the V.Manasa Ram garu and for the introduction of topic and and all the CME committee members, V.Manasa Ram garu, Dr. Vishal Inla garu, and Dr. P. Ranjit Kumar. Is very thankful to all the people and all the participants who have really joined. Hope that they'll carry the things and they will going to implement them in their daily practice. Really, it's going to be very blessing to many practitioners. At least some improvement really would have been brought by this seminar. And I thank all the IPS AP State Branch members, office bearers, Narasimha Rao sir, Sharat Chandra sir, G.S. Murthy sir, Vijay Reddy sir, and Radhika Reddy madam. Not but not the least, Sun Pharma for sponsoring this CME webinar. Thank you, everyone.
Thank you.
Good night, sir.
Good night.